Today I'm joined by my colleague and good friend, Associate Professor Denis Crimmins. Denis has been a neurologist on the Central Coast for the past 30 years, and his wealth of knowledge and experience shines through in this conversation. Join us as we dive into the difference between headaches and migraines, red flag symptoms that should make you see your doctor, and the latest discoveries in the treatments of migraine, dementia, and Parkinson's disease. I learned so much in this episode, and I hope you'll get something out of it too. Let's get into it. Professor Crimmins, welcome to the podcast. Thank you so much for coming in. Obviously, the listeners don't necessarily know this. We work in the same building, so mostly you're just Denis to me. So obviously you're a neurologist. Some of our listeners might not know exactly what that means. What actually do neurologists do, and who goes to see you?
Yeah, a lot of people have trouble distinguishing the surgeon from the physician, and a neurologist deals mainly with the brain and nervous system in a non-surgical manner. So we look after patients with common diseases that everyone knows: multiple sclerosis, stroke, migraine, nerve damage and muscle damage, and also epilepsy is another big one that we deal with. So we deal with mainly the non-surgical aspects of the brain and nervous system.
Okay. And so at medical school, or when did you decide that this was going to be your specialty? What was your journey?
Yeah, look, it's like getting into medicine. I didn't believe I really knew what I wanted to do. So I put down medicine as the first choice and got in and found I loved it. And the same with neurology. I was very interested in lots of other things, but I had a great mentor when I was at one of the hospitals in Sydney, and his example just convinced me that neurology was what I wanted.
Okay.
That's what I did.
And did you go to uni in Sydney?
Yeah, I was at Sydney University. For people listening who know about the free university under the Whitlam years, I was in the first year of free university, and my parents certainly couldn't have afforded me to go to university to do medicine, and both me and my brother both got into medicine a year after each other, and we didn't have to pay a thing.
So we've talked a little bit about some of the things that people would come to see you with. I'd love to start with headaches and migraine, because as a GP, I see a lot of that, and I even talk to people out in the community, friends, family, and people seem to have a real difficulty distinguishing a migraine from a headache. I would say when you really have a migraine, you would know that there's a difference, but do you think you could explain that to us?
Yeah, look, and most of us will have had headaches at some stage in our lives, and we know that concept of head pain, but a migraineur will give you a different experience, because we used to call them migraine headaches, and now we call them the migraine process. So if we start with migraines, it's a process whereby you get a severe and incapacitating headache, usually associated with nausea and vomiting, and sometimes preceded by some symptoms of visual disturbance, numbness, clouding of your ability to think and concentrate. And then that headache lasts hours in duration if you don't treat it. And in the end, you've got someone who's going to bed in a dark room, no noise, and feeling quite sick in the stomach, and the process goes on for a day or so. And then the day afterwards they have the headache, they have this feeling of being washed out, a hangover type effect. And that's the classical sort of migraine process we talk about. People can get other headaches associated with migraine, and if you talk to a migraine sufferer, they get other minor headaches, and we're now convinced that they're all part of the migraine process. But there are much milder sort of events, and they're still able to work. But the person who has a migraine, a ripping migraine, can't work, can't do anything, can't look after the kids, and it's a real event that knocks them out.
And at what stage, if someone has a migraine, should they be seeing a neurologist? So like, are you allowed to have one migraine a month or one migraine every 3 months before it's something that really needs to be taken a little bit more seriously?
Yeah, we've got to realise, it could be 3%, 4% of the population suffer from migraine, so it's a large number of people. And 4 out of 5 of those are females. But the majority of people who have migraine might get it once every 6 months, once every 4 or 5 months. And so therefore it becomes a pattern after a while and can be identified from other family members and friends that they have migraine. And then they'll talk to the general practitioner about what they can do with that acute event. But once you're starting to get to migraines that are occurring 2 a month, you're missing a lot of work, you're starting to see a major impact in your quality of life, and that's over a period of time, in some ways you don't need to have the neurologist to confirm it's migraine. What you want the neurologist to do is offer some sort of options by way of treatment going forward, because it's just not good for your life. And that's when the neurologist probably comes involved. Certainly if they've got other headaches which are atypical and don't have that normal sort of cadence of the way they present, seeing a neurologist is important, just for confirmation that I've got a 99% chance that I think it is migraine. I just want you to really confirm it is, and not something else.
And before we talk about treatments, I noticed you said that 4 out of 5 migraine sufferers are women. Do we know why that is?
Yeah, look, it's really quite interesting, and being a male, it's hard to authoritatively talk about the hormonal aspects of gender in regards to migraines, because the interesting thing is, the bottom line is we don't really know, because hormonal manipulation hasn't seemed to make that much difference in migraine. Whether you're on the pill, you stop the pill, you start the pill, put an IUD in place, none of these things seem to work. And in the old days, they even did things like hysterectomies and so forth, none of which made a difference. So we don't understand why females are much more overly represented in migraine sufferers, but they clearly are.
And does anything happen after the menopause? Do migraines become less, worse, stay the same? Do you see a pattern?
Good point, because the majority we don't see old migraineurs. So in other words, we know that the disease does burn itself out. And in females, it does burn itself out with menopause. There is an occasional female who actually develops their headaches during menopause, and then they've got it into older age, very rare. And we also know there's a bit of an acceleration of migraine just before the full menopause. Right, okay. And that can precede menopause by 1, 2, 3 years.
Right, okay.
Yeah.
And so interestingly, you're saying that you don't see people in their sort of 70s or 80s who are suffering with migraine, really?
You see them, but there's 2 things that happen. Maybe you become more stoic as you get older, and you're able to put up with a lot more pain, and you don't see it as a problem anymore, and you've had it all your life, and that's what you do. But no, we don't get that really incapacitated migraine in older age very commonly.
Okay. And I know there's been a lot of advances and changes in the treatment of migraine over the last 10 years. Can you talk us through a little bit of that?
Yeah, look, I tell the patients these days that, look, and I have to admit here, I've got something terrible to say, but I've never had a headache in my life. And here I deal with people with migraines, and everyone in my family suffers from migraines, so I feel quite left out, but in a good way. There's never been a better time, probably, to have bad migraine because of the therapies that are available. And the therapies are not to reverse the condition or anything, but to treat the headaches and symptoms. And the new therapies are both in the acute phase and in the preventative phase. And it's all come about because of the discovery of this receptor within the brain and the body called the CGRP receptor. It's a calcitonin receptor that we know if we stimulate this receptor, we give everyone migraines, even if you've never suffered from a migraine. And in the same person, if you block this receptor, you turn the headache off. And that's been the major advance in the last 3 or 4 years as to where our therapies are now targeting. And it looks like all the therapies we were using in the past, the final common denominator of how they worked was on this receptor, and we never knew it. just as an aside, the other nice thing is that it was an Australian who actually discovered the receptor, and probably will end up getting a laureate from his discovery.
Amazing.
Yeah, Peter Goadsby. So all the new therapies are based around this receptor. So the acute treatments, what we call the GPANT group of medications, are going to be released targeting this receptor. Tremendous acute treatments that have practically no side effects and have about a 60-70% chance of down-regulating acute headache. And then we have a whole group of medications that some are available and some will become available, which have a 3-month, 1-month duration of treatment blocking the receptor. And
amazing.
They're available now.
I know that you're very involved and interested in research. Have you been working with some of these medications at the research stage?
Yeah, look, we were very fortunate when the triptans were first. We've been doing it since the triptans, and we did clinical trials on all the triptans, and they were just. Some of your listeners would know about drugs such as Migraine and Naramig and Maxalt and Zomig and Relpax. There's so many of them. They dramatically changed treatment of migraine in the mid-90s. And so we were involved in all those studies, and we've been involved with medications such as Topomax and so forth, and now we've moved into these newer drugs as well, testing them on people.
So it's an exciting time.
It is. These you get excited about things. I'm a bit further on in my career, and this has been one of the diseases that has really just revolutionarily changed in the last 2 years.
Yeah, amazing. And so far so good. The people you've treated with these new medications, has it been transformative?
Oh yeah, look, it's amazing when you see a transformative event. So these people might be having 2 or 3 migraines a month. Their lives were a mess, and all of a sudden they'll come back and they'll go, 3 months I haven't had one headache, which, to someone who doesn't have regular migraine, you don't realise how much a difference in life that really does make.
And what's the mechanism for botulinum toxin in migraine? How is that working?
That's exactly the same mechanism. So we know in migraine there's a cervicotrigeminal system involved, because you only get headaches in certain parts of your head. It's your forehead, your temple area, around the occipital area, and sometimes into the shoulders. And it's a circuit. So once the headache starts, it feeds back on the circuit. So blocking the CGRP inhibitor centrally, well, that breaks the circuit. But Botox breaks the circuit from a peripheral point of view through the nociceptors between the skin and the muscle. So we target those the trigeminal areas where headache occurs, mainly the frontal and the temple areas, but also the occipital areas, which is the C1 region, and then down into the shoulders, which is a C2, cervical 2 region. So it breaks the loop of migraine from a different end of the circuit.
And if you find that quite successful?
Oh yeah, Botox has been, before we had the CGRP inhibitors, Botox also made a dramatic change to migraine, and migraine's one of those diseases, people come back if it works. And, as you know, with Botox, people keep coming back. And so that it makes major differences in their lives, even to be injected, yeah.
I'm really interested in what lifestyle changes can make a difference for migraines. Can you speak to that in terms of, has research shown us that you can manipulate migraines from a lifestyle perspective?
Yeah, definitely so. So when I do my mud maps to the patients, I talk about acute treatments, I talk about preventative therapies, and we probably should mention, even vitamin supplementation we know is a preventative approach with people with migraines.
Is there a specific vitamin or?
Oh yeah, there's 3 really good ones. Vitamin B2, riboflavin, magnesium, and coenzyme Q10. And we know that makes a significant difference in phase 3 studies that have shown to be effective. So in some ways it's a no-brainer. A lot of people should try things like that first.
Yeah, absolutely.
But lifestyle, without doubt, is very important. And, there's some cornerstones and they're pretty simplistic, but in actual fact, a lot of people don't abide by them, and it really comes down to fluids, making sure good hydration's in place. I always mention food, and food is more skipping meals, which is not good for migraine. Sleep, making sure that you've got good sleep habit.
Though, does too much sleep, can that be a trigger if people sleep too much with the migraine?
Oh, it's too much. The slothful person probably does not do well with migraine, but it is a little bit hard because migraineurs do that. If you're a bad migraineur, you want to sleep because that's the only part of your life which is pain-free.
Yeah.
So you can see why people do go to bed.
The reason I mention it just is I have a couple of patients and they find that it's maybe a routine thing more, but if they have a sleep in on a Saturday or Sunday, they find that they have a migraine. It's like they've slept too long.
Yeah. No, but you also go, because there is, there's all variations of migraine. My brother gets migraine, the other doctor, but he used to get what's called the letdown migraine. So he could do all his exams. The day after his exams, he used to get migraine. The first day of holidays, he gets migraine. And so on Saturdays and Sundays, he always gets migraines. So is it the sleeping in, or is it just the
relaxation?
The relaxation. And then the other big thing about alcohol and stress is another lifestyle one. Very important. But they're all very important and exercise. People who exercise do better with migraine than people who don't.
Okay, amazing. And so the other thing that people come to see me about is headaches and a fear that they have a brain tumour. People seem to make that jump quite quickly, and I do understand that because they've maybe recently read about some unfortunate person on Facebook or whatever who has a brain tumour, and then they become really paranoid that they've got a brain tumour themselves. And I know as doctors we talk about red flag symptoms or that you would be worried about. What would you say about red flags, and when should you be worried about a headache and go and see a doctor?
Yeah, look, as an anecdotal observation, I don't see many people who have got headaches and end up having a brain tumour. They usually have something else. They've got weakness that would say they've got a brain tumour, or they've had epilepsy and they've got a brain tumour. But just headache per se is probably not that high as you would think. But we don't underplay the importance of reading your body. And if you have an acute onset of severe, incapacitating headaches, which you've never had before, you've got to see someone and discuss it. Because, yes, there could be something there. The likelihood that there's going to be something bad there is probably going to be small, but you don't sit on it. That goes without saying. Or if the headache's associated with something else. So if you've got fever and headache, you see someone. If you've got weakness and headache, you see someone. If you can't think and you've got a headache, you see someone. But it's usually new onset headache associated with other symptoms are really red flags to do something about it.
Yeah, I agree, 100%. I would love now to talk a little bit about memory issues. So there's sort of two groups of people I see with memory issues. So I definitely see some women in the perimenopause, postmenopause, who are struggling with their memory. And I believe it's probably hormonal. And then another group I see are obviously more elderly people who are beginning to be forgetful, or their relatives are starting to notice that they're a bit forgetful. And I'd love you to talk a little bit about memory issues and when you should be concerned and when it's not concerning.
Yeah, look, it's very topical because we know, and when you say you're worried about memory issues as an individual, are you worried because of the issues that you're seeing, or are you interpreting things that you're doing is it a forerunner of a major illness to come? And the major illness everyone worries about is Alzheimer's disease or disease-related dementia. But quite rightly, I think you've got to differentiate. There are lots of reasons why you can have memory issues which are not dementia, but there's also memory issues which do signify that there's something going on. So the commonest cause in younger people of perceived memory problems is attentional issues. If you can't concentrate on what's being told to you or what you're reading, and it never gets into the noggin, it's not a memory problem, it's just that you don't have that concentration required. Now, the concentration distractors may be myriad. It could be stress, it could be anxiety, it could be chemotherapy that you've had for cancer, it could be medications and drugs that you're on, you're drinking too much. And so there's lots of things that will affect attention, but it gives you a perceived memory problem. And certainly that's not dementia. But then there is the group who, with good attention, still can't remember things. And that's the forerunner of a process that might be going on in the brain which can cause dementia. The only difficult thing now is that we used to think dementia was a disease of the 70s and 80s. Just in our clinic, we're now seeing most of our Alzheimer's diseases in the 50s and 60s. We're actually now able to pick it up before you're running around outside with your underpants on your head or whatever. That there is changes occurring in 50 and 60-year-olds where dementia is present. But the majority of people do have this attentional issue which leads to perceived memory problems. And this is where this term even brain fog has come up. It's a very real thing, but it's not cognitive as we would expect it to be.
And in terms of, where have we got to with dementia? I mean, are things looking a little bit brighter from the research side of things? Are we understanding the process a bit more? Because I feel like a lot of the treatments or medications that have come out, I mean, there haven't been a huge number, but I don't know, as a GP, they felt a little disappointing. Is there anything on the horizon?
Yeah, look, so there's two aspects of that. One is it's a bit like migraine. Can you treat the underlying condition and try to manipulate or change that? Or can you treat the symptoms better? Treating the symptoms is a little bit hard because there's only a few things you can give to rev up the rest of the brain to make your memory better. And there's neurotransmitters in the brain which you can try to augment, whether it be acetylcholine, noradrenaline, dopamine, and so forth. And you can give agents to try to boost those, but that's not going to change the underlying disease. But just recently now, we've got a whole stack of new agents that actually take the offending protein out of the brain in Alzheimer's disease, which is amyloid or tau. We're able to take it out of the brain, and taking it out of the brain hopefully will will change the outcome of the disease, because the substrate causing the neurofibrillary tangles and plaques is now diminished. And so the new agents we've got now, and 3 are going to be available in Australia for general use this year, actually take these things out of the brain, and it does slow the progression of the disease for the first time. So we're seeing that for the first time.
So can I just take you back a little step just to explain to the listeners? So what we understand at this point with dementia is that they've got abnormal proteins accumulating in the brain that are causing tangles, which means that messages in simple terms aren't moving around the brain like they should. Is that kind of the gist of it?
Yeah, look, and you probably need to take even one step back. The brain cells you're born with are the brain cells you die with. Probably less a few, because a few have died along the way, depending on how much you drink and do other things. So it's the only system within the body where you get no new cells. So your skin, your gut, and so forth is not the skin or gut you were born with. It's changed many times. So if you get problems occurring within the brain, those poor brain cells have to work with it. And if you get the build-up of these abnormal proteins, one is called amyloid and the other one's called tau, and there's subsets of those different ones, they start to coalesce and form these toxic things within the brain called tangles and plaques. And these tangles and plaques interfere with memory, interfere with walking, interfere with nearly every function of the brain in telling the body what to do. So what you try to do is make sure that those abnormal proteins, you take them out of the brain before they can start making their damage. That's what these treatments do.
And so these new medications are literally something you take orally and somehow it goes to your brain and kind of mops these proteins up, is that?
Yeah, look, it may be a little bit more than that, Shauna, but and unfortunately they're not oral yet, but they will be becoming oral. Most of them are infusible or given under the skin, and they cross the blood-brain barrier, and then so the abnormal protein is called amyloid or tau, and what happens is they bind those proteins, and you can actually measure those proteins in the urine, so you can see it taking it out. And we can even do scans of the brain where we measure how much tau and amyloid, and you do research projects we've been doing, we measure the tau and amyloid before we give the drug, and we know 6 months later we can't measure amyloid and tau in the brain, so they just strip it right out.
And in the research, what are we noticing people improving again, or is it just that they're not deteriorating further?
Yeah, look, that's very good, that point you make, because it's hard with neurodegenerative or any degenerative disease where it's a downward slope, because if you can change the direction of the slope or the height of the slope, that's positive. We're not going to see much significant improvement. We're going to make sure the slope is much, much more gentle. And the research would suggest, you could stop people, and I know this sounds very pessimistic, stop going into nursing homes by 2 to 3 years. But 2 to 3 years, if that's how much you slow someone going to a nursing home, can be a change to close to about 800,000 or 900,000 people in an Australian population. And they'll die from heart disease or whatever, but not end up in a nursing home because of their dementia. But the other thing, which is the most important thing, if you have dementia and you have full-blown dementia, these drugs are not going to make that much difference. Okay. We have to get the patients much earlier in their history and so forth.
And do we know why certain people have these amyloid and tau proteins and other people don't?
Yeah, look, very good point. So some of it undoubtedly is genetics. We know, in broad terms, in neurology, if you have any neurodegenerative disease, Parkinson's, Alzheimer's, motor neurone disease, any of the weird and wonderful diseases that neurologists see, if you have a first-degree relative with one of those, you've got a 20 times greater chance of you getting one of those at some stage in your life. So undoubtedly all of them have a genetic component. We don't know if it's a genetic predisposition to an environmental insult or it's a true, degenerative disease. But the other big thing is age. So, by the time you're 85, 90, about 1 in 3 people will have dementia. And, 80 will be about 1 in 4, 75 will be about 1 in 5, and it goes down. So the longer you live, just because of the basis of neurons. So there are specific genes, and presenilin 1 and presenilin 2 and APO and AB beta amyloid genes, and they're autosomal dominant, will predispose you to Alzheimer's, but that's only about 3 or 4%. The rest are, we think, a genetic predisposition and age.
And do we encourage people to get genetic testing for this or not really?
No, we don't do a Chris Hemsworth and go on a TV program and get surprised by an ApoE blood test and scare the hell out of everyone with the result, because ApoE is useful, but not really useful in determining whether you're going to get dementia or not.
Yeah, absolutely. And probably just instills a lot of fear.
Oh, it does. And I always tell people that if you come to me with, I diagnose you with Alzheimer's disease, and your father had Alzheimer's disease, your two brothers had Alzheimer's disease, we probably would do genetic testing. But if you're great aunt on your father's side, he might have been married to had Alzheimer's disease, and you got Alzheimer's disease, no. If you're under the age of 50 or 65, under the age of 55 or 50, and I diagnose you with Alzheimer's disease, you get genetic testing.
Okay. And in terms of what's the difference between Alzheimer's and dementia?
Good. I always use the Coca-Cola thing. So Coca-Cola is a cola, but you've got Coca-Cola, Pepsi-Cola, Burt's Cola, there's different varieties of it. Dementia just means a progressive fall in memory and cognition. And there's lots of subsets. So there's Alzheimer's disease, which is the most common, which is about 60, 70% of cases. Parkinson's disease is another big one in that group of dementias. Stroke and vascular disease. And then we have a lot of rare ones, frontotemporal dementia and so forth, which are much rarer. But it's just the type of dementia is Alzheimer's disease. That when we cut the brain open, that's what you see, Alzheimer's disease.
Okay. And in terms of prevention, as you talked about, we've got these brain cells. They're the same ones from the moment we're born to the moment we die. So probably we need to look after our brains more than anything else in our body, because we've got one chance. Is there anything that we can do to prevent getting a dementia?
Yeah, look, and when we see a new patient with Alzheimer's disease, and remember, I should use the term dementia, we have people with memory problems who don't have dementia, that they're called prodromal, mild cognitive impairment, then they move into the dementia range. But we do know that if at the very start of any of these issues of memory, lifestyle is without doubt the most important thing that you can attend to from the very start. And the big one we tried to mention straight away is exercise, but being a bit smarter with our exercise. You can never look at an influencer for exercise when you're about 60. What you have to do is you have to be doing exercise where you're puffy, and you have to do weights. And you have to do those too. And most of the time we set people up with exercise physiologists and get them into labs to learn how to do this sort of thing. Drugs and alcohol, goes without saying. Alcohol is so pervasive now in our older population, it really has to be dismantled somehow. The cheapness of alcohol and its accessibility when you retire just has to be somehow changed. Certainly diet, and we know the Mediterranean diet, as much as it's always talked about, it does work. There are people doing so much better when they're doing these sorts of things. Maintaining socialisation and family ties. You don't move away from your family. When you get sick, you stay with them if you can. And they're simple, but they're so important.
Yeah, interesting. I definitely have had a few patients recently who've retired and moved sort of 4 or 5 hours away, and they've moved away from kids and grandkids. And I have to say, I always think, not sure that's such a good idea. Maybe they're sick of being the babysitter, but I think from that loneliness perspective and just having care and interaction, I think maybe people forget how important that is to keep their brain healthy.
And it's also network. I don't think the brain when you're young establishes network and is probably more amenable to change. When you get older, your ability to form new networks is actually much more limited, and you fall back into a social conservatism. You don't do things. You just stay at home and watch TV. So if you move, you've got to really be prepared to put yourself out there.
Yeah, and
otherwise,
try to make new friends.
Otherwise, you just, you may as well not have moved.
Yeah, absolutely. The other group of people who sometimes present with memory issues, and I think it's quite topical, is these sports people who've had head injury. And I wonder, could you talk a little bit about that? Because I am, as you know, the mum of 4. My husband played rugby. My oldest son played a lot of rugby. We definitely had some concussions, and I think we've definitely all become a lot more aware of the significance of those head injuries. What have you seen as a neurologist in that context?
Look, it is very topical because, there's sporting injuries, but also people have had car accidents and, have had significant head injuries when they were younger or work-related injuries. Do they have an impact? There's no doubt it's very real. And, but again, I think you need to approach those people in exactly the same way as we were talking before, is that in a young person who presents, a 30-year-old or 40-year-old person who says, I've really got a terrible memory, or by the way, I got knocked out 4 times when I was playing rugby league, for the Trojans, or I shouldn't say it's rugby union for the Trojans, but for the Terrigal Sharks or whatever. It still is going to be an attentional problem, not dementia. But you have to be aware of it. You have to see a progression over a period of time, and then you have to have measurable changes when you do. I haven't mentioned the testing, but we do neuropsychological profiling of people to see what their memory profile looks like, and you would do that with that sort of person. But the majority of people who have been knocked out when they were younger don't go on to develop this thing called CTE, or chronic traumatic encephalopathy. But it does exist, and there's no doubt about it.
What about things like fish oils and doing crossword puzzles and Sudoku and all things like that to try and keep your brain active and sharp? I mean, are there any things like that you would advocate your patients to do?
Look, they all make a difference. I find, I feel, yes, you can do all those things, and you should do those things. You should take up Wordle and so forth, because they do make a difference. But I like to do it through exercise, because in actual fact, doing exercise not at home but with other people, you do all those things. You're socialising, you're stimulating the mind, because it's not just the exercise. And there was a very good study looking at a 5-kilometre treadmill test with cognition, and you do the treadmill test at home, and that's all you did. You did a 5-kilometre walk around the same block, or you do it a 5-kilometre walk where you changed the route and you didn't know which the route was going to be every day. Cognitively, it was that order. The people who changed the route every day doing their 5-kilometre walk cognitively did so much better than the people who just did the treadmill. So it tells you that the exercise does other stuff. And it does Sudoku for you. It does those sort of things through the stimulation.
Yeah.
And I think that's very important.
So I saw another really interesting study with patients with an early dementia who were sent to dancing classes. And that seemed to have a really amazing impact. I think it was obviously they were interacting with a partner. They were obviously having fun, listening to an instructor, listening to music and having to follow a rhythm and learning a new skill, like some basic steps. And that seemed to make a difference as well.
Yeah, look, and exercise, didn't they? So they've covered all the bases with that one activity. And yeah, there's no doubt. And we even see it, and I'm not going to go off topic here, but in Parkinson's disease, we see the same benefit. And it doesn't matter if you go to our boxing classes that we organise, physiotherapy classes that we organise. We've got another singing group that we organise for Parkinson's disease. You find the niche that fits you, but you have to do these things, and they make a difference in neurodegeneration. And dementia should be no different.
I'd love to talk to you actually about Parkinson's. I think most people have heard of Parkinson's disease, and they probably think of stiffness and maybe tremors as being one of the symptoms. But I think a lot of people don't understand that there is often a dementia element to the symptoms, but I'd love you to tell us a little bit about Parkinson's disease and, how it presents.
Yeah, look, Parkinson's disease is another one of the neurodegenerative diseases that are very common in our society. Unfortunately, it's also one of the diseases which is increasing, it's increasing in incidence. So the numbers per head of population is going up. We don't understand that fully. But it presents with the motor aspects of Parkinson's disease, which is usually slowing. That's the most important thing. Simple things such as walking become slower, getting in and out of chairs become slower, rolling over in bed becomes slower, voices become softer, and doing small motor tasks with your hands, such as doing up buttons, handwriting, all can become affected. And it's a very gradual onset that a lot of people put down to age, but in actual fact it's Parkinson's disease. A lot of people mention tremor, but tremor isn't the most common aspect of the disease. It's these other things, and only about 30% of people actually get the classical pill rolling tremor that occurs with Parkinson's disease, and the tremor actually doesn't affect them. So it's these other motor aspects with slowness and balance and so forth where the disease progresses. There is what we call non-motor aspects of the disease, and that includes things like memory, blood pressure being a bit low, gut changes, and even things like sleep disturbance. You can get these very rare, intrusive REM sleep disturbances where people wake up having terrible nightmares and so forth while still asleep. If they occur late in life, they've nearly got about an 80 or 90% chance of getting Parkinson's disease later on.
Okay, and any new developments with Parkinson's?
It's probably not as good by way of treatment. We talked about neurotransmitters. In dementia, it's acetylcholine. In Parkinson's disease, it's a thing called dopamine, and the brain is not producing this thing called dopamine, and the treatments are really giving or replenishing dopamine and improving symptoms. But we still haven't stopped the progression of the disease, though the things that we are looking at, mainly through the Michael J. Fox group in the United States, they're looking at a protein, again, another protein. We talked about amyloid and tau for Alzheimer's disease. In Parkinson's disease, it's called alpha-synuclein, and what they're trying to do is take that out of the brain through similar mechanisms that we're doing with dementia for Alzheimer's disease. But we haven't got as far in doing that.
And is there a sex difference between Parkinson's in males versus females, or is it pretty similar?
It's not too far different. And some studies will say actually it's more females than males, but it seems to be fairly across the board. The difference, of course, with Parkinson's is it can occur, in people in their 20s, all the way into people into their older age.
And in neurological conditions, if you get it earlier, do the symptoms seem to be worse and more rapid? So if you get like an earlier dementia or an earlier Parkinson's, does it tend to progress more quickly, or is that not really a rule of thumb?
No, it's a good point, again, because most neurodegenerative neurological diseases, by the time you start to see symptoms, things have been going on in the brain for 10, 15 years. So if you get a disease in your 20s, either two things have happened. It started when you were 8 or 9, or whatever the process is now condensed. It's a much more aggressive process that's at play. And so therefore, in younger people, especially in genetic neurodegenerative disease, there is this thing called anticipation that you seem to get a bad disease if you get it younger. So in saying that, people like Michael J. Fox is a good example. He was diagnosed in his late 20s.
I was just thinking
and
that.
Here he is still in his 50s, and he's still kicking along quite disabled, but still performing at a high level in regards to lots of things he does.
The thing, even early in my career, I realized quite quickly was in neurology, a lot of diagnosis was made really clinically based on history and examination, because often things like MRIs of brain and things weren't terribly helpful. Have we moved on in terms of imaging or being able to diagnose things more accurately?
Yeah, look, there's no doubt now. The imaging modalities of the brain and the nervous system has changed dramatically. You're quite right. The examination was very paramount in neurology to determine the disease, because there was nothing to confirm it. Now we've got imaging techniques, whether it be MRI, PET, even an older technique, but now it's got a total renaissance, lumbar puncturing.
I've been having all these lumbar puncture results coming through on my patients recently, and I've been thinking, wow, gosh, everyone's now having a lumbar puncture. So this is to look for these proteins?
Yes, and it's the closest thing to a brain biopsy we can do.
And so is it normal for everyone to have a small amount of those proteins, and if it's more than a certain amount, that's a red flag? Or if you've got a normal brain, should you have no amyloid and no tau?
Yeah. So, yes, it's exactly right. So, in other words, with the lumbar puncture, we can now say 100% you do not have Alzheimer's disease because of the levels that we find. And we can also say conversely that, you know, you might only forget your wife's name every second day, but the lumbar puncture does confirm you have Alzheimer's disease. And we know that you will progress down that pathway. So it's fairly accurate, yes.
And are those people then going to be the prime people to be put on these newer medications that are in the...
Yeah, look, there is no doubt if you get all these people early, give them that disease-modifying therapy, it's got to be the only way to go. You can't have established disease.
Yeah. So obviously neurological conditions are obviously, you know, they're awful for anyone who's having them, but the reality is that, you know, there is some good news on the horizon. There are definitely some... You know, all this research and years of investment are paying off in terms of treatments, and, you know, hopefully we're going to start getting people, you know, some results. I wanted to talk to you about one other condition that people worry about a lot. Again, in general practice, I think we see a lot of people worried that they've got multiple sclerosis. And I think, you know, a lot of them we don't refer to the neurologist because we're pretty happy that they don't. But obviously, if someone was beginning to, you know, trip or feel like they're a bit clumsy, or they're starting to drop things, or, you know, what are the symptoms that you would be concerned and be saying, look, you really need to go and have a chat with someone?
Yeah, look, it's always very hard to try to tell people when they should see their doctor and when they shouldn't see their doctor, because in the end, if you're worried about something and, you know, retrospectively it was fairly true, even going to your local, there was a reason why you were worried about it. And I don't think we should downplay that to take it on yourself sometimes to make the decision that I've got nothing to worry about. But there's no doubt any of those symptoms that you described, you know, weakness, numbness, tingling, memory issues and so forth, in the context of possible MS, yes, you've got to talk to someone about it and try to weed out what could be relevant and what isn't relevant. You know, I see 30-year-old marathon running females who said, you know, I can't stride out with my left leg, you know, for that 42nd kilometre as well as I could. And they end up having MS, you know, and I go, wow, you know.
They're very in tune.
They're very in tune with their body, but you'll also get lots of other people who are saying those same things, and it's clear that they're just worrying about something they shouldn't be worrying about. I think the good news is with technology, MRI is one of those tests now that sorts people out pretty quickly. So I think you need to talk it through. On the Central Coast, we've got a population, 350, 360,000. We've probably only got about 800, 900 people with MS on the coast. So it's not as many as you would think.
Yeah. And is there more women with MS than men?
Yeah, it does seem to be, again, but not like migraine and so forth. It might be 60-40, something like that. Again, we don't understand why, except in MS, there is, we think it's that combination of genetic predisposition and some vector that they've been exposed to, whether it be viral or whatever in early life, that produces the autoimmunity that is associated with MS. It's an autoimmune disease where the body attacks its own brain and spinal cord. So there seems to be that process at play.
And have the treatments moved on at all in terms of MS?
Again, you talked about, when I first started neurology, there were no treatments for no diseases. We could give people Parkinson's. I think that was about it. We didn't do anything for stroke or for MS or for Alzheimer's or any of these diseases. MS was the first disease in neurology which really has changed. We do not see people in hospital now with MS. When I was a trainee, we had wards full of people with MS in wheelchairs and so forth. That does not happen hardly ever now. MS is a disease that's been changed dramatically by the disease-modifying therapies, and they're only getting better. Each year there's new ones coming out which are much more effective, less side effects. It's just quite amazing.
Yeah, so it's a pretty interesting specialty to be in, and you've watched such an evolution over really a short period of time. The last topic I want to talk to you about is carpal tunnel. So the good thing about carpal tunnel is that it's not, it's very annoying and very painful for anyone who has it, but it's not a long-lasting degenerative condition. But can you just tell us a little bit about the symptoms of carpal tunnel and what you need to do about it?
Well, this is a personal one because I've had carpal tunnel. I've had it decompressed. So basically, it's your hands going to sleep painfully all the time. And you normally find it occurs at night, and all of a sudden you wake up and your hands are numb and you shake them to try to get feeling back into them. And you do that and you go to sleep again. It wakes you up again.
Do we know why it keeps happening at night time?
It's something to do with circulation and movement. You don't move your arms and so forth, so you're probably getting more fluid pooling in your arms and hands. And, of course, the transverse ligament under which the median nerve transverses is a tight little compartment, and fluid probably builds up there and then it becomes symptomatic. And it occurs mainly at night. But people will also notice it if they worked in the garden, worked with some tools, power tools or something where there's a vibration in it, that it's worse that night they do it. When they drive a car, they'll notice they have to take their hand off the steering wheel. And pregnancy is another one where fluid build-up occurs. So a lot of women get transitory symptomatic carpal tunnel during their pregnancy, which goes away with the birth of the baby. But very, very common. Can't say how many people we see a day having tests for carpal tunnel. It is that common because this silly-looking ligament has no role of any purpose in life except give you carpal tunnel.
So we've got a design flaw, have we?
We have a design flaw because it used to be there when we used to walk on all fours, and it protected the important nerves against damage. But we don't seem to walk on all fours anymore, but it does give us carpal tunnel. And you can get a similar thing in your feet, which is a lot less common, tarsal tunnel syndrome as well, but that's much less frequent.
And so is the main treatment just go in and surgically decompress, or is there any other way around it?
Yeah, look, I tell everyone, and especially if you look at their age, you need surgery. Now, whether you have the surgery now or in 5 years' time, it doesn't matter, but you're going to need it at some stage. You can wear splints, you can have injections, you can do all those things, but you're going to have surgery at some time. The only thing you don't want to leave it too long is you can potentially get weakness of the thumb in this muscle here, and that's very important for what's called apposition of the digits, which is very important for fine movement.
Yeah, so don't leave it too long, basically.
Don't leave it but it's really easy because you just can't put up with it any longer. You just say, look, my life's a mess, I can't sleep. You never get to that weakness stage because you're still the symptom stage, yeah. And
is the diagnosis always done with nerve conduction studies, or can you just diagnose it clinically and then go straight to surgery?
Look, most general practitioners who refer to us for the nerve test, which is what we do, and that objectively says it's there, have already said, patient's got carpal tunnel, can you do nerve conduction studies? So everyone's made the diagnosis. Probably in this day and age with, if things go wrong, complications, which is very rare with the surgery, it is good to see that you did have carpal tunnel to start with.
Have surgery unnecessarily.
Yeah.
Okay. Dennis, I have absolutely loved this conversation. I could pick your brain all day. You're clearly a very intelligent man. I would love us to summarize with 5 tips for people to look after their brain. I know that we've talked about some of them, but if we could just pull them together.
Look, I come back to exactly what I was saying before. I think exercise, but not exercise that is in popular press. It's doing something that's a little bit puffy.
What do you mean by that?
So you got to be short of breath.
Okay.
And you got to have a drop of sweat on you somewhere. Now, it could be between 2 telegraph poles on your 5-kilometre walk or a slight incline, but you do something where you're trying to push yourself a bit beyond. But the other big thing is weights. And what I mean by weights is you can use weights, but you can do Pilates or anything where, resistance is important. I think alcohol and drugs of abuse, you just got to really be aware of the damage that it does cause long term. Maintaining social networks is so important, and that can be within family, with friends. And it's a very good point you make. Always think about, why would you want to move? Stay where you are if it's all well set up for you. And diet, the Mediterranean diet does seem to protect the brain and the tissue.
Okay, amazing. So if you could talk to your 20-something self, Dennis, what piece of advice would you give yourself?
Well, the first one, because I looked at this and I thought, 1979, My Shauna was the biggest song. Apple computers, that was the first personal computer, was released in that year.
Should have bought shares. That's what you should have
bought shares. From the more philosophical thing, I would say to myself, Dennis, stay in neurology because things will get better. And they certainly did. But I think, I think most of us, just making sure you don't get scared of uncertainties, take a few risks, but not silly risks, and realise making mistakes is a good learning experience. I think I always found that very good just doing medicine.
Yeah,
don't get too worried about the mistakes.
Yeah, absolutely. It must have been pretty hard at the beginning in neurology because you're right, there really wasn't much that you could do for anyone at the beginning but be really kind and empathetic.
It was very cerebral. We used to sit and talk about lots of things and decide we couldn't do anything.
Yeah, gosh, that's tricky. Well, Dennis, thank you so much. You have been amazing. I know I definitely going to want to bring you back and pick your brain all about stroke and lots of other things. But thank you for being so generous with your time.
Thank you, Shauna.
If you enjoyed this episode, I'd really love you to leave a review or share with someone who you believe would benefit from hearing this conversation. This podcast and any information, advice, opinions, or statements within it do not constitute medical, healthcare, or other professional advice. Information is provided for educational and entertainment purposes only. If you have any health concerns, always consult your doctor.